Assalamu alaikum. My name is Dr. Shakaib Qureshi. My topic of presentation today is a disease with many faces. Thank you for inviting me to RheumaCon. I'm actually a director of rheumatology at UBMC and also teach at Vista Medical School as associate professor. So let's start the talk. I'm going to present a couple of cases. The first case is 70 years old female who presented to us with chief complaints of pain and stiffness in the hands, chronic low back pain and knee pain. The past medical history of a usual 70 years old with hypertension, leg edema, answering bursitis, knee osteoarthritis, AFib. Your routine medications such as ibuprofen, no major family history of any inflammatory arthritis. Review system, she also had dry mouth and dry eyes, anxiety, insomnia, chronic fatigue. She's a retired school teacher. When we examined her, we found that she has findings of inflammatory arthritis with synovitis of her bilateral wrist joints with reduced range of motion, active synovitis in the right, second, and third MCP joints greater than the left hand, synovitis in the right hand, PIP joints greater in the right hand compared to the left hand, and findings of degenerative changes such as bilateral trochanteric bursitis, anserine bursitis, Aberdeen's and Bouchard nodes, and bilateral knee crepitus. She had bilateral pitting edema of the legs. So like in any other case of inflammatory arthritis, we did the basic investigation such as CBC, RFTs, LFTs, urinalysis came unremarkable. Uric acid was okay, TSH was normal, ENA was entirely negative, and along with anti-Uintah antibodies were negative as well. Rheumatoid factor CCP, hepatitis viral panel negative, HLA-B27 negative. The patient had CT angiogram chest done a few months prior to presentation was negative. The X-rays of the patient showed these very subtle early changes of lacy reticular pattern in the PIPs and in the proximal and distal interphalangeal joints, phalanges, and some erosive changes in the wrist joints. And this is her pelvic examination. The SI joints seem to be okay, and the hip joints are slight sclerotic changes, but nothing major. Now, this is not her hand X-rays, but this is hand X-rays of a patient who had advanced changes of the same illness that we are dealing with. So it shows very elaborate kind of cystic changes in the phalanges, as you can see. And you can also see the arthritis mutilans, basically a dissolution of the distal phalanges. Same patient had the feet changes, similar radiographic changes in the feet. And this is somebody's spine, MRI scan of the spine of the patient. The arrows show where the active lesions of sarcoidosis are, and the lower part shows the compression fracture. This is another patient's hand films pictures, which basically shows PIP joint swelling, DIP joint swelling. There are dystrophic nail changes, but there's no pitting, which differentiates it from psoriatic arthritis. Sarcoid arthritis, now we will discuss that, can be chronic. That this patient had a history of sarcoidosis years ago prior to presentation. No details were available, but according to the patient, she had rotary gland swelling and lung involvement, and she was given steroid for 6 months when she was diagnosed years ago. What was reassuring was that recently her CT scan of the chest was negative for active pulmonary sarcoidosis. So the arthritic symptoms that she had were very typical: prolonged morning stiffness, pain, swelling, and the radiographic changes. There was not a rheumatologist in the area, so she could not go anywhere for years. We started her on standard treatment, hydroxychloroquine, and we added methotrexate, and she, with titration of methotrexate, she noticed about 50% overall improvement. Since she had 50% improvement, we discussed about a trial of infliximab, and she agreed to that. We started her on infliximab, and it led to much better improvement in the joint pain, stiffness. On examination, she has had almost total resolution of her synovitis. Her range of motion of the joints much improved, quality of life much improved. So chronic sarcoid arthritis, this is what it was, can involve the knees, ankle, wrist, hands, and mostly it is polyarticular, mostly it is Jacob's arthropathy. How do we differentiate it mostly from rheumatoid arthritis? Obviously, the blood test positivity in rheumatoid arthritis is a separate helpful points, but at the same time, if you tap a joint, it will be much milder inflammatory infiltrate in sarcoid joint versus rheumatoid joint. Monoarthritis is rare. In chronic sarcoid arthritis, And you have to rule it out by comparing it from gouty arthritis and septic arthritis and CPPD. Treatment, as we did, non-steroidal anti-inflammatory drug with low dose of steroids. You can add the DMARDs. And then the DMARDs, the methotrexate, has been the most studied and has more evidence compared to the other ones. But the other ones have also been tried if methotrexate is contraindicated and you can't put patients with biologics, such as sulfasalazine, hydroxychloroquine, leflunomide, azathioprine, and minocycline. So the main biologics which have been helpful so far in the literature are infliximab and Humira. Second case. The second case is more of an acute sarcoid arthritis versus a chronic case that we presented. There was a local nurse who came to us from a teaching hospital for the main presentation was acute onset of bilateral ankle pain and swelling. But at the same time, she also complained about painful skin nodules in her calf bilaterally. It started almost at the same time. On presentation, she had low-grade fever, like 100.5, and an examination also revealed she had acute synovitis of her bilateral ankle joints, and an examination also revealed tender erythematous, painful nodules in her calves. We ordered the basic tests as we previously have. I've shown you, along with TB testing, because you want to make sure that there's no tuberculosis, especially with painful skin nodules. ESR was 62%, 62, and on HS X-ray she had bilateral hilar pulmonary lymph nodes. Strong suggestion of sarcoidosis. So she was started on celecoxib for 7 days, and then prednisolone was given. And the patient improved on the second visit in 7 days, about 50%. The steroids were tapered off in 4 weeks. The patient never showed up after that. This is what we call Lofgren syndrome. As we know that sarcoidosis incidence is more common in the blacks, more common in the females. Its incidence is higher in Sweden than UK, Korea. Sarcoidosis is a rare disease in Korea. So there is a geographical distribution as well. Lofgren syndrome was first described by Swedish pulmonologist Sven Lofgren. And the main features of Lofgren syndrome are acute polyarthritis, and along with hilar lymphadenopathy, low-grade fever, ESR, and E-nodosum. Mostly the arthritis is bilaterally symmetrical, and ankles are very commonly involved. More than 90% of the cases, ankles would be involved, but other joints can be involved, such as hand, feet, wrist, elbows. And you're going to find evidence of synovitis on examination. Obviously, we do take the baseline X-ray of the joints, but they're mostly non-revealing. The inflammatory markers are raised in more than 80% of the cases. Important thing to remember is that uveitis and the ACE levels can be normal. So there's no uveitis, no ACE levels elevation in case of Lofgren syndrome. So that is one differentiating feature. Typically, it's a self-limiting disease, which means that it's got a very good prognosis, and patients mostly improve rapidly. And in 2 years, very few people, like such as 8%, will have symptoms after 2 years, or 6% would have recurrent disease. Otherwise, they mostly cure themselves after the treatment. Non-steroidal and colchicine can be given for milder disease and recurrent or difficult disease and more burden of disease steroids. This is a sample of a CAT scan of somebody's lungs, which shows the mediastinal widening of in both hilar and trachea, and then the second one, the B, shows multiple enlarged lymph nodes. Erythema nodosum is so this is the picture of E nodosum in a patient with sarcoidosis, and it shows the circle shows where the nodules are, which are painful, and they mostly come with a fever and the rest of the symptom that we talked about. If you do a biopsy of the lesions of the lymph nodes, then you will find these epithelioid cells with multinucleated giant cells, and it's mostly non-caseating granulomas. Brief history of sarcoidosis. Sarcoidosis was first described by Hutchinson in 1878, and then there were a lot of different scientists who then found the further features of sarcoidosis. Sarcoidosis is, along with syphilis, is considered to be the greatest mimicker. Mimicker means that it can involve any organ, and it's got a lot of extra articular, extra pulmonary manifestations. Hutchison's, as I said, described the first case in 1878, and he called it gout in the MCP joints. So at that time, obviously, the gout was a main inflammatory arthritis known. So they thought it was a gout in the MCP's joints. Lupus pernio was a phrase which a French dermatologist, Ernest Berznier, gave in a male patient, where he found that there were large, livid, purplish, red, shiny nose, and then skin lesions on the cheek, swelling in the fingers. And he said that it resembled lupus vulgaris. Lupus vulgaris used to be a very common TB skin condition, and hence he gave this name lupus pernio. So lupus vulgaris-like lesions, along with chilblain-like lesions in the nose, coined this term called lupus pernio. Obviously, it was not lupus, it was not TB, it was not one of any of these illnesses. Later on, Caesar Boy coined the term sarcoidosis, like flesh-like lesions of the skin, and lymph node biopsy histologically showed sarcoma giant cells. Hence, he coined this term sarcoidosis. Then Karl Kreibach in Prague was the one who found out the X-ray changes in the joints, and he felt that it was non-tuberculosis. But at that time, the authorities at that point almost forced him to admit that it was not a non-tuberculous process going on. So going further, then further, as I said, like different medical doctors as they came along, found out other manifestation: Schwenn-Lofgren, pulmonary involvement; Hereford, UV parotid fever; Mucklitz found out in salivary and lacrimal gland involvement. And then Lofgren was the one who we just described the case, found out this his own syndrome. And then sarcoidosis of the heart was described in 1944. A little bit about sarcoidosis. It's more common in the African American and females. There are certain risk factors. So there are certain genetic risk factors, such as HLA-DR3B3 is more common in Lofgren syndrome, and HLA-A1 and B8 with arthritis and good prognosis. There are a lot more investigation going on. I don't want to go into that detail because of the time frame involved. Environmental exposure. So if you have exposed to mold and mildew at work, or Mycobacterium TB, Borrelia, dog fly, and herpes, then you can have a high risk of developing sarcoidosis. Environmental exposure. There was a study done in World Trade Centers survivors and workers, and the people who were more exposed for a longer period of time were the ones who had a higher incidence of sarcoidosis eventually. Obesity and weight gain is, and then there is a high risk of concomitant illnesses such as Sjogren's syndrome, ankylosing spondylitis, SLE, lymphoma, liver cancer, skin cancer, and VTE. So if you take a biopsy, you'll find caseating. So this picture shows non-caseating granulomas versus caseating granulomas. As we know, caseating granulomas are more common in the TB, and non-caseating granulomas is sarcoidosis, which is very helpful biopsy differentiating point. Clinical course can be, as I said, acute versus chronic. It can be chronic progressive. The most important thing when you find a patient with sarcoidosis is to see the extent of the disease. So if you find pulmonary, you have to really dig into and do a very massive research to find out that if there is any other organ involvement or not, because then it changes your clinical management course. Typically, when a lung is involved, we do the staging stage. Staging stage means that you do a chest X-ray. Stage 0 has no abnormalities. Stage 1 has lymphadenopathy. Stage 2 has lymphadenopathy plus pulmonary infiltrates. Stage 3 has pulmonary infiltrates. Stage 4 is fibrosis, which is the most difficult, and it carries the worst prognosis. When you do a HRCT, you're going to find these are the important things to remember. There are certain reversible parenchymal abnormalities such as micronodules, macronodules, ground glass opacities, and irreversible parenchymal abnormalities where it's not going to change with your medical management, at least, is honeycombing, cyst, bully, emphysema, architectural distortion, which has already happened, traction bronchiectasis, volume loss in the upper lobes, and mycetoma, which can be present in 10% of the patients with end-stage sarcoidosis. In any patient of pulmonary sarcoidosis, you're going to develop a baseline. So chest X-ray, HRCT, PFTs with DLCO have to be done. And mostly, if there's an active involvement of the lungs, decreased TLC, RB, FEV1, FVC, and DLCO. So the way we diagnose sarcoidosis is obviously with compatible clinical findings and radiographic finding and histological evidence. You have to rule out other granulomatous diseases such as tuberculosis, borreliosis, leprosy, hypersensitivity, pneumonitis, Crohn's disease, PBC, and fungal disease. The standard of care now is to do an endobronchial ultrasound biopsy, fine needle aspiration biopsy, because it carries the least amount of invasiveness and morbidity involved and the highest yield. Treatment of pulmonary sarcoidosis. Very important point to remember is that every patient of pulmonary sarcoidosis does not require treatment. A lot of patients have, there's a high proportion of the patient who are asymptomatic and they're incidentally found by a chest X-ray or a CAT scan for some other reason. And if they're asymptomatic, you're not going to treat them. And because the disease can be non-progressive or can repeat on its own. The favorable characteristic is stage 1 lung disease. And if the patient has obviously enodosm, or if there is absence of other symptoms, and if they're of European descent with no therapy of steroids required then. Unfavorable prognostic factors are such as symptoms on presentation such as dyspnea is very important, multi-system involvement of more than 3 organs, and increasing chest chest X-ray abnormalities, extrapulmonary manifestations such as skin, bone, joints. So those are important, or if any vital organs are involved, which we'll discuss quickly soon. Indication for treatment of pulmonary sarcoidosis is if you especially have cough, shortness of breath, and if you have chest pain or discomfort or hemoptysis, or if you have deteriorating lung function such as 10% reduction in TLC over the period of time, 15% or more of FVC reduction, or DLC of 20% or more reduction, or if the 6-minute walk test shows decrease in oxygen saturation of 4 or more %, or if you have progressive radiographic changes on further X-rays, worsening of interstitial opacities, development of cavities, progression of fibrosis with honeycombing, or development of signs of pulmonary hypertension. Treatment. Really, the treatment is going to be steroids. I'm not going to go into that detail because of the matter of time. PFTs and chest X-ray can be repeated in 4 to 6 weeks. A tapering of steroids is required within 6 months to a year. 1/3 of cases may relapse after we taper the steroids and may require lifelong steroids. For patients, so there are certain subsets of patients who may only have cough, which may be just a airway hyperreactivity. And if they're stage 1 or even stage 2, you can probably get away by giving them inhaled glucocorticoids and save them from the systemic steroids side effects. If you have a refractory pulmonary sarcoidosis, then methotrexate can be added, as a thiopurine could be a second-line agent, which is probably equally efficacious for lung disease, but carries more side effects. Hydroxychloroquine can be given for cutaneous involvement or hypercalcemia. And if none of this is working, we can obviously add infliximab or adalimumab. Refractory disease management, as I just mentioned, infliximab and adalimumab has more data. And if there's a lot of evidence of chronic fibrotic disease, then nintedanib and pirfenidone have shown benefit. There is studies going on with JAK-STAT signaling pathway, and eventually it may be one of the novel treatment options for sarcoidosis. Multi-system disease, and I'll skip this slide quickly. Let's go to the important manifestation. Neurosarcoidosis is one of the most important ones where it can be life-threatening as well. So you have to really do a detailed evaluation of patient in this regard. Typically, cranial nerve involvement, facial nerve involvement can be there, which can mimic Lyme's disease. Hence, they have to be ruled out. Hereford syndrome is a rare manifestation of neurosarcoidosis with facial nerve palsy along with parotid gland enlargement, interior uveitis, and fever. Needs treatment. Carpal tunnel syndrome can be present. Vestibulocochlear nerve involvement can give balance and hearing issues. Cerebellar involvement, such as balance issues with ataxia. Chronic meningitis can present with leptomeningeal or pachymeningeal involvement. Imaging of choice is MRI scan. PET scan has to be done to see the extent of the disease. And then if the biopsy, as we know, if there is any extra CNS organ available, or any like such as lymph nodes are available, then that biopsy is preferred over more invasive brain biopsy. Depending upon what is the manifestation, the treatment options are steroid, pulse treatment, methotrexate, cyclophosphamide, anti-TNF, cyclosporin, or brain radiation. Sarcoidosis is another very dreaded kind of complication. It can be present in asymptomatic patients as well. So sudden death can occur from ventricular tachyarrhythmias. Conduction block can be one of the other causes of death caused by cardiac sarcoidosis. AV block is one of the commonest manifestations in the people who have bad cardiac sarcoidosis, and ventricular arrhythmias can be cause of the can be terminal arrhythmias for the cause of the death. Presence of cardiomyopathy and heart failure can be present in the patients who have extra cardiac sarcoidosis. Hence, a baseline echocardiogram, EKG should be done on every patient. The most specific testing to be done for cardiac sarcoidosis is to do a cardiac magnetic resonance imaging with late gadolinium enhancement can be found, and a cardiac PET CT can be done to see the extent of the disease, and can also give you a prognostic and treatment options. The patients who have increased burden of myocardial scar tissue and in the presence of left or right ventricular dysfunction are at a very high risk of developing sustained VTAC. These patients often require implantable cardioverter defibrillator. This is the picture of the late gadolinium enhancement of the cardiac sarcoidosis lesion. The arrows point out towards areas with myocardial involvement by sarcoidosis. The patients who have cardiac involvement, such as heart failure, LV dysfunction, heart blocks, ventricular arrhythmias, and definite evidence of active myocardial inflammation by PET CT or myocardial histology, immunosuppressive therapy is strongly indicated to further reduce the progression of the disease. Patients with the right ventricular involvement carry a worse prognosis and more likely to benefit from aggressive therapy. For the patients who have asymptomatic patients with normal LVF and right ventricular ejection fraction, then we have to do the evaluation of the burden of the disease by doing the PET scan for the rest of the body involvement. Treatment is basically steroids along with methotrexate. Anti-TNFs can be also carefully added because anti-TNF can, as we know, can worsen the CHF in the patients who are predisposed to having CHF. ICD should be given to the patients with ejection fraction less than 35%, abrupt onset syncope, imaging evidence of scar for secondary prevention of patients who have sustained VTAC or VFib or survivors of sudden cardiac arrest. Cutaneous sarcoidosis quickly, nudism, papule of the sarcoidosis in the leg, plaque of sarcoidosis in the face, multiple plaques of sarcoidosis on the trunk, lupus pernio in the on the nose, sarcoidosis of the scalp. Treatment of cutaneous sarcoidosis, localized treatment on the localized involvement on the trunk or extremities, topical intralesional steroids can be used, and then systemic agents are reserved for mostly widespread progressive lesions, or if the patient is having a major disability from the skin lesions, and then prednisone can be given orally for such kind of patients for 4 to 6 weeks. If the lesions are not responding, you can add hydroxychloroquine or methotrexate. Doxycycline or minocycline can also be effective. For rail-resistant cases, infliximab, adalimumab, or thalidomide have a role. Quickly, ocular sarcoidosis. It's quite common in systemic sarcoidosis. At least every patient should get a once a year eye exam. Interior uveitis, posterior uveitis, conjunctivitis, corneal involvement, orbital involvement, eyelid involvement can take place. Interior uveitis mostly presents with pain, redness, photophobia, blurred vision, and it responds well to the treatment. If it becomes chronic, then it shows chronic mutton fat KPs. It carries higher complication then. The posterior uveitis shows candle wax dripping sign. It's painless, floaters, blurred vision, and you really have to screen for neurological involvement because that's the most dreaded complication of ocular sarcoidosis. This picture quickly shows anterior segment with interior granulomatous uveitis with mutton fat KPs. The second picture shows multifocal chorioretinal lesions. The third one shows the candle wax dripping of the sarcoid uveitis of the posterior uveitis. And the lower picture shows the multiple lumpy, bumpy subconjunctival involvement with sarcoidosis. Quickly, the other symptoms involvement, extraocular involvement of lacrimal glands with the resultant dry eyes, less involvement of the exocrine glands such as salivary and parotid glands with subsequent similarity to Sika syndrome. Endocrine and reproductive organs can be involved, such as hypothalamic involvement with subsequent manifestation, infiltration of the thyroid gland, Uterus, ovaries, testicular can have its own implications. Renal involvement with calcium abnormalities and electrolyte imbalances. A baseline serum calcium should be obtained in everyone, and the complication could be nephrocalcinosis and nephrolithiasis. The rare complications are interstitial nephritis and membranous nephropathy, where obviously you will require systemic treatment. Gastrointestinal involvement, areas of involvement include esophageal involvement, appendix, colon, rectum, liver, pancreas, rarely small intestine. In summary, final slide, multi-system disease, great mimicker. Once suspected and diagnosed, do intensive baseline investigation and work up to see the extent of the disease. Very important, because your treatment will depend on that. The extent of the treatment will depend on that. The pulmonary system is the commonest to get involved, but not everyone needs to be treated in pulmonary involvement. That is the point to be taken. Treatment mostly requires a multidisciplinary approach, which may involve a pulmonologist, rheumatologist, cardiologist, internist, and dermatologist. Treatment mostly is indicated for pulmonary, cardiac, arthritic, CNS involvement, hypercalcemia, LFT abnormalities. Once suspected and diagnosed, do not panic, take a deep breath, go through my slides and call me if I'm needed. Thank you very much for your time.